There are two types of bronchitis, acute and chronic, but for this presentation I'll be focusing on acute bronchitis. Bronchitis is characterized by the inflammation and narrowing of the bronchial tubes of the lower respiratory tract. Acute bronchitis commonly follows a viral infection such as the flu virus or common cold and is usually self-limiting. But even after the infection has been killed, the cough can linger for several months afterwards. People at high risk for developing this disease process are people with underdeveloped immune systems, aged immune systems, compromised immune systems, and people taking medications that suppress the immune system. So this would be the very young, the very old, people with disease processes such as cancer or HIV, and people on medications that lower your immune system. Other things that can cause acute bronchitis would be inhaled irritants such as cigarette smoke, dust, pollen, vapors, fumes, and air pollution. Acute bronchitis presents like pneumonia, with the only difference being there is no presence of pulmonary consolidation.
Clinical manifestations of bronchitis include subjective and objective symptoms. Subjective data is what the patient states they are feeling. This includes a headache, dyspnea, which is shortness of breath, myalgia, which is muscle aches. They can be defined as deep, constant, dull aches, malaise, general weakness or the feeling of being tired, chest pain, hoarseness, or sputum. Objective data is information that is gathered by a measurement or observation. This can be defined as fever, cough, or sputum. Cough and sputum can be both objective and subjective data because the patient can state they have a cough or sputum, and it can be observed during the assessment.
Diagnostic test for bronchitis. Unfortunately, there is no definitive way to diagnose bronchitis, as it is usually based on the provider's clinical assessment. The patient's lungs, upon auscultation, may be normal, wheezing, or crackles upon expiration or exertion. The temperature of the patient may be elevated. With cough being the most common symptom of bronchitis, the doctor may order a sputum culture to test for bacterial infection and confirm with the patient how long the cough has been present. If the doctor orders an X-ray, it would show up normal with no consolidation. The doctor may also order a blood test to monitor for a possible infection, as well as possibly ordering a pulmonary function test to determine if there is an alternative reason for the symptoms, such as asthma. Tests, such as the X-ray and sputum cultures, are usually used to ensure the patient does not have pneumonia or another type of respiratory infection. This would complete the doctor's evaluation of the patient and help them rule out any other possible causes for the patient's symptoms, thus allowing them to give the diagnosis of bronchitis.
Let's talk about common medications for bronchitis. This includes cough suppressants, bronchodilators, glucocorticoids, and antivirals. Cough suppressants are necessary because coughing is one of the most common symptoms associated with bronchitis. The way the cough suppressants work is by suppressing the cough reflex by acting on the cough control center in the medulla. Some common cough suppressants are guaifenesin, codeine, and benzonatate. Guaifenesin and codeine are considered opioid antitussives, whereas benzonatate is a non-opioid antitussive. Some common side effects of cough suppressants are drowsiness, dizziness, headaches, nausea, vomiting, and diarrhea. Bronchodilators, especially beta-2 agonists, are commonly used in the form of inhalers. Bronchodilators do exactly what the name states. They dilate the bronchioles, then they increase the airflow to the lungs. Beta-2 agonists are specifically discussed for the treatment of bronchitis. Some medications that fall under this are albuterol, formoterol, and levolbuterol. When using an inhaler, it's important to teach the patients the correct use, and a spacer can be provided to improve the delivery of the drug. Some side effects of bronchodilators are tremors, headaches, nervousness, palpitations, and an increased pulse. Next are the glucocorticoids, which are most commonly used for chronic bronchitis to reduce inflammation. Glucocorticoids are believed to have a synergistic effect with the beta-2 agonist that we were discussing in the bronchodilators. Some of the side effects associated with orally inhaled glucocorticoids are throat irritation, hoarseness, dry mouth, and coughing. Finally, antivirals are often used if the bronchitis is caused by an influenza virus. Some of the common antiviral medications are zanamivir or oseltamivir, which are started within 48 hours of the start of the symptoms.
Treatments for bronchitis are increased fluid intake by 1 to 3 liters a day. This will loosen secretions and make them easier for the patient to clear. Deep breathing and coughing exercises. Instruct the patient to take a deep breath, hold for several seconds, and then cough forcefully through the mouth using the abdominal muscles. This exercise makes the cough more effective in clearing mucus. Use of the incentive spirometer increases airway expansion, prevents atelectasis, and gives the patient visual feedback. Small, frequent meals are recommended for patients with dyspnea. The small meals are easier to tolerate. They should be high in calories and nutrients. Encourage the patient to exercise as tolerated. Mobility helps prevent atelectasis and further complications, but it is also important for the patient to rest and allow the body to recover. Instruct the patient to sit upright at 30 to 45 degrees. This increases maximum lung expansion and prevents aspiration. Oxygen therapy as needed if oxygen saturation falls below 90%. Chest physiotherapy is used for patients with thick mucus excretions that are difficult to expel. It consists of percussion and vibration. Percussion is use of a cupped hand to gently drum along the patient's back. Vibration is the use of a flattened hand on the patient's back and moving the hand in a shaking motion. Both interventions clear thickened mucus from the bronchioles to larger airways. Chest physiotherapy should only be used by a trained professional.
Now we're going to discuss 3 nursing diagnoses that are appropriate for a patient with bronchitis. So the first one that we're discussing is ineffective airway clearance, and this is related to the excretion of excessively thickened mucus, and it's evidenced by excessive sputum, coughing, alteration in respiratory rate, wheezing, shortness of breath, and restlessness. Then we'll move on to the second possible nursing diagnosis, which is impaired gas exchange, and this is related to airway obstruction by excretions. This is evidenced by altered breathing patterns, restlessness, wheezing, excessive sputum, being short of breath, and coughing. Finally, the third one is a little patient-specific, so this would be for a patient who is a smoker. Smoking can really irritate the lungs and it can cause bronchitis. Therefore, the nursing diagnosis for this patient could possibly be readiness for enhanced health management related to wanting to stop smoking, since smoking is a great contributor to the development of bronchitis. This is evidenced by the patient expressing a desire to change daily habits, expressing a desire to join a smoking cessation program, or to try a patch, or to try different methods to cope with this addiction in order to decrease their smoking, thus decreasing the likelihood of developing bronchitis.
For this slide, we're going to be going over potential complications for bronchitis, starting with the most life-threatening, going down to the least life-threatening. First, we have septic shock related to unchecked infection gone bad. So a patient may have developed the infection and which gave them the acute bronchitis. They didn't go to the hospital, maybe because of a disparity, developed sepsis, ended up in the emergency department, and then developed septic shock. So to prevent this, we want to treat the underlying cause. So we will get culture and sensitivity, and we will start the patient on a course of antibiotics while we await those results. To identify this, we look towards vital signs and labs. So we'll have an increased respiratory rate, increased heart rate, and decreased blood pressure. Skin will be warm, and we will have a fever and chills. The patient will have a decreased level of consciousness as well. With the labs, we will have neutropenia, which is a very low white blood cell count caused by the systemic immune response using up all our available white blood cells. We will have a low pH. We will have an increased blood glucose level due to the increased metabolism caused by the infection. And towards the end, if efforts have been exhausted, the patient will develop disseminated intravascular coagulation due to the cytokines and lytic enzymes that were brought on from that immune response, going and tearing up everything, including the vasculature systemically in the patient. This would make holes all over the capillary beds and all over the vasculature all over the body, and would cause the patient to bleed out everywhere. Next, we have acute respiratory failure related to pneumonia, which would be related to the acute bronchitis. So this is due to damaged lung tissue causing an impaired gas exchange. So prevention would be, again, to treat the infection. So we want to treat that underlying cause, get the culture and sensitivity, start them on a course of antibiotics, and give them oxygen. So to identify this, we'll look at vital signs. We'll have an increased heart rate, increased respirations. We'll look at how they present with shortness of breath. We'll do a focused respiratory assessment. We'll look for adventitious lung sounds such as crackles, and we'll see that the patient has secretions from the pulmonary edema and coughing up the mucus that they have. Labs will see that the arterial blood gases will have a low partial pressure of O2 arterially, less than 80 millimeters per mercury, and the partial pressure of the CO2 arterially will be greater than 45 millimeters per mercury, and this will be the hypercapnia that we see with the patient. They'll have a decreased level of consciousness and confusion. We could also look at things such as cyanosis from the decreased perfusion, and that's how you identify the acute respiratory failure. Next, we have pneumonia related to bacterial respiratory infection. This is an immune response that caused leaky membranes within the alveoli, and patients that have acute bronchitis can develop pneumonia. So to prevent this, we want to treat the infection. We want to prevent aspiration, since people with acute bronchitis will have mucus coming up with their cough or some sort of sputum. We want to make sure that they don't aspirate any of that. We'll do a culture and sensitivity and start the patient on antibiotics, await those results. Identification of this is usually through a chest x-ray, where we can see pulmonary edema and pleural effusions. We're going to do a focused respiratory assessment looking for pulmonary consolidation, crackles. The patient will present with tachypnea, tachycardia. They'll have a fever. Labs will have a elevated white blood cell count initially. And we'll look at the partial pressure of O2 will also be decreased with the arterial reading. So we'll look at the arterial blood gases and see that the O2 is down because of that fluid in the alveolar spaces, causing a disruption in the diffusion of oxygen and CO2. We have chronic bronchitis related to repeated episodes of acute bronchitis. This can result from repeated bouts of acute bronchitis. To prevent this, we treat the infection, don't smoke, promote hygiene, and avoid pollutants such as chemicals or vapors that can irritate the lungs. To identify this, we look to see that there is a presence of a productive cough for at least 3 months in each of 2 consecutive years. We want to look at if the patient has mucus hypersecretions, and we'll do a chest x-ray to view if there's any alveolar inflammation or any fluid buildup that we would see in those alveolar spaces.